So in our nerves, all throughout the body, we have insulation called the myelin sheath, correct? So the myelin sheath serves as it facilitates transmission of nerve impulses from one muscle to the next, okay, making it smooth. So now I can move, pick up this bottle, no problem. Okay, my movements are coordinated, it's smooth. So acetylcholine is released. Acetylcholine makes nerve transmission possible, right? So as long as the myelin sheath is intact, it's going to result in well coordinated, smooth muscle movements. Now comes multiple sclerosis. So this is a autoimmune problem causing demyelination of the nerve fibers. It's thought to be autoimmune. We have no cure for MS because it's immune mediated. So therefore, what do you think the treatment is going to be? It's going to be immunosuppressants. Okay, so this is a chronic condition, no cure. It's going to be a lifelong illness. It's going to be controlled with immune modulators. So we're going to give the patient immunosuppressants. And the rest of the treatment will be symptomatic, mainly to control pain, because these patients will have pain. The most debilitating, which most of these patients will become disabled, is next to the fatigue is the pain. And of course, they have the uncoordinated muscle movement, so it makes working impossible. So you've heard of some celebrities having MS, pretty much ends their careers, although they can still work somehow if they get the disorder controlled. They can control the tremors and the pain. Then some of them can still work. Some can even have children. Okay. The peak is between 20 and 50 years. So all of us are still within the range of the disorder. So this is what happens. So this is our nerve fibers, and we have the myelin sheath that covers each nerve fiber. And it's these myelin sheaths that are destroyed by autoantibodies. It's not a continuous destruction. So the patient will still have intact myelin sheaths and some continuous path of stretch of nerve fibers, but then there will be patches of demyelination. So it will result in nerve transmission okay in some areas, but then it will be interrupted in some sections. So it's not going to result in a continuous and coordinated muscle movements, okay, which will account for the symptoms. Again, we don't know the cause. It's we just somehow develop autoantibodies leading to the destruction of the myelin sheath. It tends to occur in people who already have autoimmune disorders. Okay, so it may go in happen in families. So let's say one family member has, let's say, another autoimmune disorder, say Crohn's disease or ulcerative colitis, and then another family member will have MS. Okay, so it's really strange. We don't know, again, the cause, so there's no way to prevent it, and there's no cure, just like any other autoimmune disorder. It's not easy to diagnose also. There's really no test that will say, oh, this test shows you have MS. It's clinically diagnosed. The MRIs, the CAT scans done here is, again, to rule out other causes. So let's say they'll look at your brain. Is it Parkinson's? Because the symptoms resemble Parkinson's. But then they'll say, okay, no evidence of Parkinson's, so it's not Parkinson's. Okay, so that's the testing. There's really no test that says, oh, the test shows you have MS. Okay, it's clinically diagnosed based on clinical signs and symptoms. So these are the manifestations. The most common type is the relapsing remission type of MS. There's some chance of symptom-free periods as long as the patient complies with the medications, the treatments. However, there will be exacerbations, flare-ups. An MS episode can flare up, usually triggered by stress. And again, stress is very subjective. So it can be triggered by an emotional event. Some life event occurs, or let's say at work, the patient is overstressed, like exams, for instance, coming up. Or it could be an illness also. So anything stressful can trigger a relapse, a exacerbation. Most symptoms begin in the eye. So the patient will have, which again contributes to the patient unable to work because they'll have the double vision, the blurring of vision. I mean, how do you focus on work, right? I mean, we need our intact vision for anything we do, correct? Then fatigue, as I already mentioned, is the one of the most debilitating part of the disorder. The patient simply has no energy to do anything. So they lay in bed. And because you're between 20 and 50, what are you supposed to be doing between that age range? It's supposed to be your most productive years, right? But then you can't work because of the symptoms. So now the patient also develops depression, okay, anxiety, and all other psychiatric or psychologic problems. Extreme temperatures also, hot temperatures, although it's not just hot, but also extremes. Cold temperatures can also trigger a relapse and therefore a flare-up of the disorder. I already mentioned pain. So pain is another common symptom. So the fatigue and the pain between those two, you can't hold a job. Most patients are females. We do have a few that are males, but mostly MS patients are females. Contributing to the pain is the spasticity. Patients will have muscle spasms, particularly in the back. That contributes to the pain. Spasms are painful as well. They will have the following genitourinary manifestations, and of course, this will affect sexual desire as well. So this can disrupt relationships. Okay, you'll have UTIs, constipation, emotional problems. I already mentioned marital conflicts will occur because intimacy is going to be affected here. The patient also has depression, if you remember that. So it's not an easy life. Let's go to treatment now. I repeat, no cure for MS. So the management is mostly symptomatic. We give them pain medications. They're on antidepressants. And for the disease itself, it's just the goal is to delay the progression of the disease, manage symptoms again, and treat flare-ups or exacerbations. I'm not testing this table because this is for the physician, obviously. This is for diagnosing MS. Go to the drug therapy now. So pharmacologic therapy. Remember RA, rheumatoid arthritis? Okay, so the treatment will be similar because it's also autoimmune, correct? RA was autoimmune, so we'll use the same similar medications here. So some of them you may also already remember. So interferons, these are injections, subcutaneous injections. So you can teach the patient here to self-administer the medications. Usually refrigerated. So these pre-filled syringes, Copaxone is the most commonly prescribed interferon. There, you've seen Lovenox, right? Enoxaparin. Okay, similar packaging. Okay, so similar pre-filled syringes. You keep it in the refrigerator though. So that drug will keep the function of that drug is to it's a disease modifying drug, yes. Yes, interferon beta 1. This is just one, okay? So we have more medications. So this is subcutaneous injection. And then we've got glatiramer. This is also another type of option. Okay, so they won't be on both. They'll either be on interferons or glatiramer acetate. Fingolimod is oral. Among these three here, we have teriflunomide, fingolimod, and dimethyl fumarate. The most commonly prescribed is the fingolimod. So on the exam, I'll likely use fingolimod because it's the most commonly prescribed among the three. The good thing is this is oral. So this is good for patients who have difficulty with the injection. So their option would be the oral, which is fingolimod. Then for exacerbations, Kiara mentioned earlier, so steroids will be used for flare-ups. Obviously, the interferons, glatiramer or fingolimod will not work anymore during flare-ups or a relapse. So the patient is in relapse, then we will use steroids, IV steroids. So they're typically hospitalized during the flare-ups because the patient will have extreme fatigue, extreme weakness. They're unable to eat and swallow. So they'll be hospitalized for IV fluids. This is another, but this option is expensive. Metosantrone is IV every 3 months, administered at a doctor's office. So this option will, do you remember hydroxyurea used in sickle cell disease? Okay, so hydroxyurea is similar to metosantrone, although this one is IV, hydroxyurea was oral. So this one is given every 3 months. Hydroxyurea was daily oral. This one is every 3 months in IV infusion to decrease the number of relapses. The rest of the treatment, as I mentioned earlier, is simply symptomatic. So they'll be given antispasmodics. So we've got muscle relaxants like dantrolene, or the cheaper option is baclofen. So this one's oral, very affordable for the muscle spasms. Then we've got for severe symptoms, severe spasticity, they'll be given benzos, Valium or diazepam. Dantrolene, you remember dantrolene, the one we use for malignant hyperthermia? Okay, so this is another muscle relaxant. The beta blockers here is not for blood pressure, it's for the tremors. Okay, so the ataxia responds well with propranolol. Among the beta blockers, though, we don't prescribe any other beta blocker except propranolol. Okay, this is to manage the ataxia, the tremors. The tremors here, by the way, is intention tremors, meaning if they're resting, you won't see any tremors. It's when they attempt to move So we call it intention tremors. That's when the tremors happen, okay? When they, let's say, want to reach out for something, or when they're walking, the tremors are very evident. But when they're resting, they're fine. Bowel and bladder problems. So these are the patient will have incontinence together with constipation. For the, meaning the bladder will become overactive. They'll have dribbles, so they become incontinent. So they'll be given anticholinergics for that. And you already know UTI medications from last semester, the nitrofurantoin, the Bactrim, okay, trimethoprim / Septra, okay, fluoroquinolones like ciprofloxacin, levofloxacin, so common UTI management. So they'll have frequent UTI episodes because of the bowel and bladder problems. You know, the incontinence will cause the UTI. That's it for MS. Do you guys ever watch these video animations? They help you remember the disorder and the treatment. Any questions on MS? Okay, let's go straight to the chronic degenerative disorders. First is, let's do Parkinson's. So another sad disorder affects the, disorder can affect about 30 years all the way to the fifth decade. So in your 30s all the way to 50s, okay, is the peak incidence for Parkinson's. So what happens in Parkinson's disease? So the patient here has this is a degenerative disorder. So progressive, no cure, gets worse over time. So the goal of treatment is to slow the progression down and to treat the symptoms. Again, no cure. The problem is in the substantia nigra part of the brain, which is where dopamine is produced. So this is a deficiency of dopamine. What is dopamine? So you remember acetylcholine, correct? From myasthenia gravis. Okay. So acetylcholine is responsible for muscle contractions because it's a neurotransmitter for muscle contraction. Okay, so if let's say you pick your nose, so I'm able to do that because I have any muscle movement. Okay, so I have acetylcholine. The ability to control the movement, however, is made possible only by dopamine, meaning there should be acetylcholine, but then there should also be dopamine. Okay, so acetylcholine makes muscle contraction possible, but for you to control, so the movement, the muscle movement, in order to make it purposeful, is you need dopamine. So dopamine also has other functions. You've probably heard dopamine in critical care patients. Like this is a drug used to increase blood pressure, correct? Okay. So dopamine has many uses. So in this particular instance, because the patient has a decreased dopamine, so since dopamine increases blood pressure, what happens to these patients' blood pressure? It'll be lower, plus what happens to movement again? Are they going to have purposeful movement? No. These patients will have tremors. The tremors here, unlike in MS, which was intention tremors, correct? This one will be resting tremors. So even at rest, especially at rest, they will not be able to stay still. So the patient will have uncontrollable tremors, and that again burns a lot of energy, correct? Because even when they're not doing anything, muscles are contracting. So therefore, they're burning through a lot of energy. The problem is there's a chewing and swallowing difficulty as well. So nutrition will suffer. They lose weight as a result because they cannot eat enough to supply the the calorie requirements, because again, the patient will have tremors. So there are, here's again the problem. It's in the substantia nigra. So this part of their brain is degenerating. It's literally deteriorating. Okay, only this part though. Not all patients will develop dementia, although some eventually will, but it's not really a classic manifestation of Parkinson's. I mean, you've seen Michael J. Fox, correct? Or Muhammad Ali. Muhammad Ali never developed dementia, right? He was intact until the day he died, correct? So there's involuntary movements, and the acronym for the major symptoms is TRAP, TRAP. So we have the tremors, we have the rigidity. Rigidity also will mean dyskinesia. And then we have akinesia, meaning no movement. They'll freeze, their muscles will freeze. Or it can also be dyskinesia, the rigidity. So tremors, rigidity, akinesia or dyskinesia. Dyskinesia can also be involuntary muscle movements. Okay? You've heard of tardive dyskinesia, correct? Meaning the smacking of the lips. So you've seen some people who are on psych medications, they have this, they do this, they do that, or let's say, uncontrollable muscle movements. That's what we call dyskinesia. And then P will be postural instability. Patient will have a forward-facing gait, propulsive gait, so that when they walk, you'll see them walk like this. It'll look like they're about to fall forward on their face. Okay, so that's the gait that the patients will have when they walk. So since the problem is a deficiency in dopamine, no problem with acetylcholine, therefore the goal of the therapy is to increase dopamine, or other drugs will also prevent dopamine from being destroyed. Or remember Guillain-Barré? Myasthenia gravis. Okay, the treatment for myasthenia gravis was pyridostigmine, right? Okay, to prevent acetylcholine from being destroyed. So they can also be used for these patients, okay? Because myasthenia gravis was weakness, correct? So these patients will also be given similar medications, although not all. But the major therapy will be to increase production of dopamine or prevent it from being destroyed. Let's go to manifestations. So we discussed the tremor. Again, the acronym is TRAP. We have tremor, rigidity, akinesia or bradykinesia, and then postural instability. So here's the tremor. Again, when do the tremors occur? During rest. Okay, so the patients will have resting tremors. So what do you notice Michael J. Fox does when he does interviews lately? What do you notice him doing? He keeps doing this, right? He keeps what do you call this? Yeah, rocking left and right. Okay, because he's figured out that as long as he keeps moving, people won't see the tremors, because when he's at rest, then you'll see the tremors. Okay, you'll probably noticed that if you looked at public appearances of the late Muhammad Ali. So he was having tremors. Okay, when he would stand, let's say for photo ops, and then lately for Michael J. Fox, he would when he's sitting and he's doing interviews. Like I watched a documentary lately when they made they were talking about the Back to the Future series, who was the original actor and then how he replaced him. So they were talking about that, and he was doing this constantly. Okay, so he was rocking in his chair and then constantly moving his arms just to avoid the tremors from occurring. So here, so it's evident when the extremities are motionless or when they're at rest. Okay, so the tremors appear during that period. And here's the rigidity. Rigidity again is the patient will have freezing episodes. So this is also part of the, not only part of the disorder, but also part of the treatment. So the medications will have some side effects of dyskinesia. So this is one disorder wherein we will cycle through several medications, because what happens when you're taking the same drug, because these patients will live indefinitely. Okay. Yeah, their lifespan is not really cut short unless they, don't receive care, and then they aspirate and get pneumonia. But typically they have relatively normal lifespans. Okay. So again, when you're taking the same drug for a long time, what happens? You said tolerance, correct? So will the drug still work? No, they stop working. Plus, they'll just suffer the side effects, right? Number one side effects of the drugs are dyskinesias. So when they start having dyskinesia, then stop this drug, will switch to another one. So after they cycle through those drugs, and then they'll go back again to the old one. Okay, and we'll talk about the drug holidays later under management. So there are 3 levels of rigidity here. So we have the most severe is the lead pipe or the cogwheel movements. You know what a cogwheel is, right? A square wheel. Imagine a car with square wheels. How will that car move? Okay, so that's the type of movement they will have. That's the type of rigidity. Okay, or lead pipe. I mean, lead pipe is solid, right? Okay, so there's varying levels of rigidity. Here's the bradykinesia. Bradykinesia is, bradycardia, slow movement. And again, during episodes where they will have the freezing episodes, meaning they've been on the drug for a long time to switch to another one, it's going to be akinesia, okay, no movement at all. And this is the postural instability. This will contribute to falls. So this is also called the shuffling gait. Shuffling gait, also some call it a propulsive right here. So propulsive gait, shuffling gait. Okay. So it's like this. That's shuffling gait. Then they have a forward-facing posture. And then they also have the when they start, so it's okay when they start moving, but when they begin, they'll have like this. So some physical therapists also call it a magnetic gait. So they're attempting to move, but then the foot feels like it's glued to the ground, and they can't move it. But once they get moving, then they have the shuffling and the propulsive gait. So this is all because of the decreased dopamine levels.
Professor, but shuffling gait is not just Parkinson's. People also.
Yeah, we have some other people who show shuffling gait, but it's mostly seen in Parkinson's patients. So just like in MS, so let's say you're in your 30s when you're afflicted with this disorder. So what will happen to you? What will be your other problems? Okay, so same thing. So patient will have depression, anxiety. We're not even talking about the drug side effects yet. We'll get to that under medical management. So these are the other problems. So I mentioned the hypotension, right? Because the dopamine levels are low. So they'll have the uncontrollable sweating, drooling, flushing. They have urinary retention, constipation, and again, sexual dysfunction. So similar effects to MS. Dysphagia contributes to the weight loss. They'll have problems chewing and swallowing. They'll lose weight, but then they're burning through again their energy stores because of the tremors that they'll be having. A small percentage again will have dementia, but not really everybody. So never assume because they'll have this mask-like face. You saw Muhammad Ali, right? So he didn't have any more facial expressions, right? He couldn't smile, right? Even if he wanted to. So they have this poker face, or the actual term is mask-like face. Doesn't move. Patients in the advanced stages of the disease will develop hallucinations. So they'll start seeing things, especially in the mirror, for instance. And then eventually, late in the disorder, they'll have psychosis. Complications will be shared between MS and Parkinson's, or with any other movement disorders. These patients will have skin breakdown, muscle contractures, or joint contractures, falls, and respiratory conditions will arise. Pneumonia, usually aspiration pneumonia, UTIs as well, because they'll have urinary retention. For diagnosis, like I said, the evidence will show the degeneration of the substantia nigra part of the brain, and then the dopamine levels in the blood will be low. Medicines. Okay, so there's several here. First, and the cheapest way is to give them levodopa and carbidopa. Why the combination? This is called Sinemet. So this is the first drug given to the Parkinson's patients. It's the most cost-effective, cheapest. Levodopa is the dopamine. Okay, so the drug becomes dopamine when it crosses the blood-brain barrier. The problem is, what's the blood-brain barrier supposed to do? Why do we have a blood-brain barrier? Okay, to prevent harmful substances, including medications, from crossing into the brain circulation, correct? Okay, so this is a challenge with the medication therapy. So we have levodopa, but most of it is destroyed when it crosses the blood-brain barrier. Now, to prevent that, we add carbidopa to prevent the destruction or metabolism of levodopa before it reaches the brain. Make sense? Okay, so we can't give them just levodopa because it won't work, because as it crosses, it'll be destroyed. So therefore, when you give it with carbidopa, which is what Sinemet is levodopa, carbidopa. So that allows levodopa, more of the levodopa, to be available as it enters the brain circulation. Okay. As already mentioned, within 5 to 10 years, patients will have the harmful side effects now, and therefore it'll be time to change the drug. Time to stop Sinemet and switch to another one, so that now the patient will have the dyskinesia. Again, the most dyskinesia movements I see are like this, like the patient will have like that, uncontrollable. Okay, so when they have interactions with people, and then they will just do that, okay, which is embarrassing, right? I mean, you're in public, people you don't know. It's okay with family, family will love you no matter what. But in other, scenarios, it's embarrassing, right? To have these movements. So because not just for Sinemet, not just for levodopa, carbidopa, the patients will have an on-off syndrome with these medications. So on meaning they work, but then they'll have these off periods wherein they will have just the dyskinesia, okay, just the off effect, meaning they'll have the symptoms, the massive symptoms of resting tremors. They'll have the freezing episodes. And here are other side effects or adverse effects from Sinemet: nausea, vomiting, appetite loss. So both the disorder and the drug can cause hypotension. And once they have hypotension, can they develop dizziness, fainting? Can they fall? Okay, so these all contribute to complications. So these patients will fall depending on the age, and then they'll break something. Now they'll be hospitalized. We will skip the surgical management because we've seen a lot of rich celebrities. Were any of them cured? So we'll skip surgical management. I mean, it's an option, but again, it doesn't really help much. Okay, so drug therapy remains the best option for controlling Parkinson's. Here are the anticholinergics. Between these two, the benztropine is the most commonly seen anticholinergic prescribed. Honestly, I've never seen trihexyphenidyl hydrochloride. I've only seen benztropine. Just like any other anticholinergic, including atropine, this will cause fluid retention, blurred vision, and because of the fluid retention, it's contraindicated in patients with glaucoma, because what will happen to the intracranial, intraocular pressure increase because there's going to be fluid retention everywhere, including in the eyes. Amantadine is an antiviral agent, but it helps with reducing rigidity somehow. Okay, this is also given to some patients with OCD, also with patients who have schizophrenia. Okay, amantadine can also prayer. So there are some, these are the side effects of amantadine. Dopamine agonist, so this will increase the production of dopamine. Bromocriptine is the only one available. Ropinirole, these are going to help with the muscle rigidity and tremors as well. You've seen this prescribed for restless leg syndrome. Restless leg was covered, I think, MedSurg 1. So ropinirole is treatment for restless legs, which can help, right, with the symptoms of Parkinson's. And these are the other drugs. You know MAOIs, right? You've discussed this in psych, mental health. Yeah. Okay. It helps also with the, remember we said either increase the production of dopamine or prevent dopamine from being destroyed. So this is now the drug that does the other one, MAOI inhibitors. Entacapone is frequently given with, there's another group of drugs that's not mentioned in the table. We call them COMT inhibitors, COMT. So I've never seen entacapone given by itself. It's usually given with COMT. Oh, wait a minute. I think this is a COMT inhibitor. Sorry. And entacapone, yeah, it is the COMT inhibitor. Sorry, I brain fart. So an entacapone is a COMT inhibitor, and it's always given with Sinemet. Okay. Both are approved by Medicare, so it's, you know, it's commonly prescribed, entacapone. Some even have, I just don't know the name of the drug, but they've combined Sinemet and entacapone in one pill. And these are your side effects. The rest of the management are, like I said, remember MS? So patients will benefit from, if they have muscle spasms, then they'll be given baclofen. If they develop depression, then they'll be put on antidepressants, anti-anxiety medications. At home, because most of these patients stay at home, or you'll see them also in nursing homes, long-term care facilities. For those who choose to stay at home, some even live alone, which sounds dangerous, right? But for those who choose to live alone, they don't want to be institutionalized. We can't force them, right? So they'll be monitored by teletherapy, home health therapy, but it's teletherapy though. So it doesn't involve daily visits. Their interactions will completely be online, FaceTime or Zoom meeting. So the nurses will, you probably get one of those jobs if you're interested. So you're doing telehealth. So all you're doing is visiting patients virtually and talking to them, make sure, are you okay with your medications? How are your symptoms? Right? So your clients will range from mostly neurologic patients, MS patients, Parkinson's patients. So it's a nice, nice job. It's one of those where in your dress, you have a nice shirt and tie, and then you're just in pajamas or your underwear, right? Or cancer patients too. They're all covered by teletherapy. So a lot of healthcare team members are involved here. So we've got physical therapy, occupational therapy. We have the speech therapist will be involved. We have the social worker. Of course, the RNs, taking care of these patients. Because this is a lifelong problem. So they'll require lifelong management. So here, if we get to that, let's say most people, nobody wants to stay in a nursing home, right? So they'll stay at home for as long as possible. And if needed, they'll have a hospital bed, easier for raising the head of the bed. Because if you have a regular bed, that means you're stuck with with placing pillows, right? Which is not very ideal. Plus, you can't put a trapeze on a regular bed. Okay, so with hospital beds, you can attach the poles for the trapeze. You know what a trapeze is? Probably seen them in post-op patients. Orthopedic units. Okay, so those hip surgeries, right? So because it's impossible to put them on a bedpan, right? So they put a trapeze and they just lift themselves up, slide the bedpan. Nutrition, of course, we will thicken fluids here. We'll cut the food piece, the meats, into small bites. Okay. Similar to stroke patients. And if they get to the point wherein swallowing is impossible, then they'll get peg tubes. Communication, be patient because they'll be slow to respond. They'll have dysphonia. Remember, dysphonia was mentioned earlier in this section. And you have two patients here. The patient and the family will also be your patients. Cause of death for these patients typically are going to be respiratory because they will eventually aspirate. They'll get pneumonia, they'll get sepsis, and die. Any questions?
They get the psychosis due to the deterioration of the part of the brain.
Yeah, because not just that part, eventually deterioration will occur elsewhere.
will spread.
Mhm. So it's typically part of dementia. So once they develop dementia, the last stage of dementia involves psychosis, right? So it's more part of that. So those percentage of patients who do develop dementia eventually will become psychotic. And these are your patient and family teachings. Okay, keeping the patient safe at home. Questions?